pregnancy, right? So it has a risk factor for DVT, and that's why none of these conditions we are going to give. Don't give it in CA breast, migraine, very, very important, and smoker. So anybody who is predisposed to any vascular condition, don't use a combined OCP. That's one blanket statement. Very, very important. What does it increase? What does it decrease? What it decreases is what is very, very important. So it decreases the risk of CEO. Remember, decrease CEO. So CEO matlab colorectal, endometrial, ovarian. With this itself, you can remember the risk factors of all cancers, in this one line. Why? Because what are OCPs essentially doing? They're decreasing the menstrual cycle. So can I say anything that decreases the menstrual cycle is going to decrease the risk of endometrium, ovary, and the other way around. Basically, anything where you have more menstrual cycles will become a risk factor. So when will you have more menstrual cycles? So can I say anybody who has early menarche or late menopause? Not give you this. What they'll give you is about parity. Who will have more menstrual cycles? Women who haven't had a child. So this is nulliparity, and this is what is one of the most commonly asked questions. Nulliparity is a risk factor. So this is how I remember that OCP decrease kar raha hai. Why is OCP decreasing? Because it is decreasing menstrual cycle. But anything that you have more menstrual cycle means more predisposition to developing endometrial or ovarian cancers, right? So that's very, very important. Now something again tricky. If they give you HRT instead of OCPs, if they say hormone replacement therapy, then all cancers are not decreased. Then colorectal definitely decrease. But what about endometrium? Now endometrial cancer ka risk increases with HRT because HRT is going to cause endometrial hyperplasia. Okay, so in the doses of estrogen that we give for HRT, you're going to have endometrial hyperplasia, which further increases the risk of C endometrium. But colorectal decreases. Okay. Cervix and breast, controversial, because imagine making a statement that OCPs, which are used by so many women, is increasing risk of breast and cervical cancer. Nobody is going to use it, right? So what you have to remember, this is disputed, right? We are not sure. Risk, definitely not. Decrease, not sure. So that's what you want to remember, that these are not decreased for sure. Whether or not it is increased or not, we are not very sure. I hope this is clear. Now let's talk about a missed pill concept. So when we talk about missed pill concept, you have to see how many pills are missed. If it is 1 or 2 pills missed, nothing, no tension. Just take one extra pill whenever you remember. Okay, so whenever you remember, just take that one extra pill in addition to the scheduled pill, and everything goes as planned. 3 or more pills, now you have to see the week. If you are in the first or second week of your menstrual cycle, not a problem. Then what do you have to do? Same. You take that one extra pill, but in addition, you will be advised that you should use some additional method of contraception. If possible, take an emergency contraceptive as well. So additional method should be taken for the next 7 days, and that's it. But what if you have missed it in the 3rd week of your menstrual cycle? This is where you have a problem. If 3 or more are missed, if 1 or 2 are missed, nothing, no problem. Just take that one extra and move on. But if 3 are missed in the 3rd week, now what to do? Now what you have to remember is you take that one extra pill. Now what you have to remember is in your OCP pill pack, what you have is going to be the non-hormonal pills. You don't have to take the non-hormonal pills. So you continue as scheduled. One extra you have taken, and now you continue as scheduled. As soon as you end all of your hormonal pills, now discard it. So discard the non-hormonal pills. Okay, so discard non-hormonal pills and start new pack. Essentially, what you are doing is woman to have a menstrual, you are not giving her that withdrawal bleed. Okay, so that is the concept here, that she will discard non-hormonal pills and she'll start a new path. Okay, so this is what you need to remember as far as the missed pill concept is concerned. Moving on to next, these are all also free of cost. So we have centromine tablet. Centromine tablet matlab chaya. This is the only non-steroidal oral contraceptive pill that we have. It is ormeloxifene. Okay, and this was developed in India by CDRI Lucknow. Okay, have it to be taken twice a week for first 3 months, once a week after 3 months. So that's pretty good. Only once a week you have to take this tablet, and very important, PCOD is a risk factor because these can lead to increased risk of ovarian cysts. Okay, very, very important for exam. This is Antara. Antara is depot-medroxyprogesterone acetate. So this is where you're giving a progesterone injection as a depot injection. So this is 150 milligram intramuscular, and this gives you protection for 3 months. So every 3 months you have to come for this injection. So imagine a woman comes later than her scheduled date. Let's say she gets late by 2 weeks. What are you going to do? A, give her DMPA. B, check her UPT and give her DMPA. Answer is just give her DMPA. The guideline is can be given up to 2 weeks earlier than her scheduled date or after 4 weeks delay as well. So as much as 1 month delay is also acceptable. You don't have to check UPT. You can give. This was asked in INICT. Okay. Then we have 2 permanent sterilization methods. So this is non-scalpel vasectomy. What you need to remember, you have to inform the male that he's not immediately sterile. Here, the sterility comes when? The sterility comes either after 3 months of the procedure or after 20 ejaculations. Okay. So this is when you get sterility. On the other hand, sterilization is tubal ligation. So you can see these rings. These are your Fallope rings. These are stylistic rings, and you can also see them as radio opaque on the X-ray here. And this is the ring applicator that is used for putting these rings. Very important questions now. What is the most common site of ligation? This is the isthmus. Why the isthmus? Because it has a uniform muscle thickness. So that's why you can ligate it. The most common cause of failure of ligation is misidentification of the tube, right? Instead of the tube, you're going to ligate the round ligament. So very, very important. Anatomy wise, you know RTO. So round ligament is anterior, then you have tube, and then you have the ovarian ligament. So instead of the fallopian tube, you misidentified it and ligated round ligament. So that's the most common cause of failure. So this is where I want to teach you some additional anatomy points, all right, which are very, very important. What is round ligament? So round ligament is essentially the derivative of gubernaculum, all right? So this is what connects the uterus or the ovary to the labia majora, right? So this is gubernaculum. What it does have is the Sampson's artery. Sampson's artery is a branch of inferior epigastric artery, okay? So these are the points about R. Then you have tube, then we have ovarian ligament. Ovarian ligament, you want to remember, has the utero-ovarian anastomosis. Remember, in PPH, we are going to study PPH. First, we ligate uterine artery, then we ligate this utero-ovarian anastomosis, which are ligated at the level of ovarian ligament. So then, where are the ovarian arteries? So this is where you will now remember that ovarian arteries are within the suspensory ligament. Suspensory ligament of ovary is also called as the infundibulopelvic ligament. Okay, so this is the ligament where you have the ovarian vessel. This is very, very commonly tested point, and this is what is affected in ovarian torsion. This is the ligament that is twisted, and that is what leads to torsion, right? So very important anatomy points here: R, T, and O. Round ligament, gubernaculum, ovarian ligament, utero-ovarian anastomosis, suspensory ligament or infundibulopelvic ligament, ovarian vessels. So then why leave out uterine vessels? So where are uterine vessels? Uterine vessels are present in the cardinal ligament. Okay, so I'm going to teach you this cardinal ligament or transverse cervical ligament. It has the uterine arteries. And in anatomy, we have studied ureter crosses here, water under the bridge, right, where ureter is posterior to the uterine artery. So this is what are the two contents of cardinal ligament. So what I have just discussed in the last 3-4 minutes is so important, and most students make a mess here, all right? So remember this part. Moving on, so where did we come from? Round ligament, okay? Interval. How tubal ligation is done most commonly is interval ligation, which means in the first 7 days of your menstrual cycle, you want to ligate because then you have more chances of pregnancy, okay? Postpartum ligation also you want to remember is usually done in the first 7 days. So the guidelines say more than 24 hours, but less than 7 days of delivery, postpartum ligation can be done. But what is important is here you will not do a laparoscopic ligation, you will do a mini lap ligation. Laparoscopy, why not? Because the uterus will be higher, right? So if you insert your laparoscopy ports, you may injure the uterus. So that's the concept. Same with MTP. In MTP, you can do concurrent, but for second trimester, same concept. That for second trimester MTP, you are going to do mini lap. Okay, so for second trimester MTP and for postpartum MTP, you will prefer a mini lap technique. When you do a mini lap technique, then you're not going to put the fallope rings. Then what is followed is the modified Pomeroy's method. That is what the government recommends. And that is where you basically take a fold of the tube like this and you're going to ligate both of these ends. Okay, so modified Pomeroy method uses chromic catgut. That's another point. Okay, so this is what you need to know. And is consent of spouse needed? No. Whoever's body, that person's consent. Okay, so this is what we need to know about all of the methods approved and given free of cost under our government. What about other contraceptives? So you just need to know a few points. What are these two? These are barrier methods. So what you see here is a and you see a vaginal sponge here. So that is today vaginal sponge. Both of these have a very high failure rate, right? So these are combined with a spermicidal agent. What is the spermicidal agent of choice? That is nonoxynol 9. Okay, so this is nonoxynol 9. What it tends to do is it inhibits the motility of the sperms. It messes with the surface tension. And that's how it's a spermicidal agent. Right, so that's two topical methods of giving contraception. If you remember in pharma, I told you estrogen, progesterone have a very high first-pass metabolism. So that's why in OCPs we actually have to give a very high dose. But when you give it topically, the dose can reduce, right? So that's what we are doing. This is given as a transcutaneous patch. You can read here Ortho Evra patch. This is where estradiol remains constant because that's the most potent estrogen. But we keep changing the progesterone. So this is where you have norelgestromin, whereas in Nuvaring you have etonogestrel. Nuvaring is again a topical ring, vaginal ring. So again a topical method of giving contraception, hormonal contraception. Then you have Norplant here. So these Norplants are these silicone capsules which are injected or put into the subcutaneous plane. This is what contains a total of 36 mg LNG, unlike 52 mg that we studied with Mirena, right? So in Mirena we had written 52 mg. This is 36 mg. So each size you don't have to remember, but each capsule is 34 into 2.4 ml, and there are 6 such capsules, and this is what gives you protection for 5 years. And the advantage of Norplant is that it is immediately reversible. Let's say that in the middle of the 5 years you decide that no, I want a child, then you can get these removed and it's immediately reversible. So that is the flexibility that it offers. So this is Norplant. Talking about POP, so this is progesterone only pill. This is Cerazette, which is Desogestrel 75 micrograms. The mechanism of action of POP is only alter cervical mucus. Remember, it does not inhibit ovulation. That has been asked. It does not change ovulation, but the timing is very strict. I mean that it has to be taken daily at the same time. Minipill gives you a window of 3 hours. That within 3 hours, you can take. For example, if I'm taking at 9 a.m. the next day, between 9 a.m. to 12 p.m. I have to take it. Cerazette, they say, is a little more forgiving. Meaning, if I'm taking at 9 a.m. between 9 a.m. to 9 p.m. I have the window of 12 hours within which it should be taken. Right. So this is about POP. This is the latest device, which is called as Issure. Issure is the only device that is inserted. This is inserted hysteroscopically via hysteroscope. So let's say this is uterus. You can put it here, right? So this is where you put it at the cornua. So this will also take around 3 months for its action to come. So now 3 months becomes a golden number for contraceptives. 3 months action of DMPA, non-scalpel vasectomy, and Issure. Both will be effective after 3 months because by this time now fibrosis will happen and the tubes get blocked. All right. So these are your newer contraceptives. Now let's talk about emergency contraceptives. Very, very important topic. So the most common emergency contraceptive is LNG. So this is your iPill morning after pill, that is LNG 1.5 milligram stat. So you have to take a single dose here, okay? So LNG 1.5 mg stat, and this should be taken within 3 days, right? Within 72 hours of unprotected intercourse. On the other hand, if I ask you what is the most effective contraceptive. So if I ask you overall, what is the most effective emergency contraceptive, then your answer will be copper T. Okay, we saw, right, that copper T is what inhibits the fertilization as well as implantation. So this is what is copper T. We can't use Mirena, remember, not Mirena. Only copper. It's the copper which is associated with that property. So copper T is the most effective emergency contraceptive, and it can be used till 5 days of emergency contraception. And ELA1, if asked what is the most effective hormonal contraceptive, then that is ELA1. It's ulipristal acetate, 30 mg tablet stat, single dose, and this also can be used for up to 5 days of unprotected intercourse. Right? So 3 main ones: LNG 1.5 mg, copper T, and ELA1 ulipristal. Okay. If they ask, can I use OCPs? Answer is yes. For that, you have a USPs regimen. Okay. So USP regimen is not used because it involves taking a very high dose of these drugs. So if you want to know the regimen, it has ethinyl estradiol, which is a total of 100 microgram, plus LNG 0.5 mg, which is taken twice 12 hours apart. So this is what is the USPs regimen: EE 100 microgram plus LNG 0.5 mg twice 12 hours apart, if asked, and mifepristone. Wherever there is mifepristone, they'll ask, can I use misoprostol then? No. No Mirena, no misoprostol. So that is what you can remember, that these two can't be used for emergency contraceptive. You can remember it as miso. So matlab no. That's why you'll not confuse it with mifepristone. Alright, it says FE, matlab YES. Okay, so you can use yes, mifepristone, miso, no. So this is about emergency contraceptives. Few one-liners. What is the contraceptive of choice for a woman who is on anticoagulation for DVT? So here, what is contraindicated? First, tell me that. OCPs are contraindicated, so we can use IUD. Opposite of this, molar pregnancy, what is contraindicated are IUD because of risk of uterine perforation. So what is best? OCPs, right? So it's like a cross mnemonic here. Postpartum, answer is in the question itself, POP. So POPs are the agent of choice more than IUD. So if given an option, go for POP because they don't alter the milk output. Anything which has estrogen in it will alter the quality and the quantity of the breast milk, and that's why the concept is postpartum, no estrogen should be there. Okay, no estrogen should be there in the contraceptive that we're using. Pearl index, so this can be asked as a mathematical question. So Pearl index means the number of accidental pregnancies per 100 women years. What does that mean? So here they give you how many females are using it for how many months, and because it's per 100 women years, multiplied. Right now, in calendar method, the Pearl index. Calendar method means you see, right, what are the expected time of ovulation around the time of ovulation. After day 14 is the high fertile period. So if you're just using that very high failure rate of 24, barrier methods like condom and vaginal sponge are 14. From 24 it becomes, please the last part. Female condom, vaginal sponge, very high chances of failure. So from 24 make it 20. Male condom make it 14. So 24, 20, 14. Other three have very good values, means low Pearl index. So IUCD is 2. Usko half karenge, OCP 1, sterilization 0.1. Right. So this is what we need to remember. Next, going on to a little bit of gynae now. So approach to enlarged ovaries. This is something we have discussed in radio as well. The radiology of urine we have seen. Now let's discuss this topic. So whenever you see that there are many follicles which are all arranged in the periphery. So now you will have learned a lot of numbers here. But let me give you a radiologist perspective here. We don't even count these numbers when we are doing a scan for PCOD. What is the most specific marker of PCOD? Do you know? It is actually the stroma. So this is the stroma, which is the thecal cell. And thecal cells were producing the androgens. So this is what is the main problem in PCOD, that the stromal volume increases and stromal echogenicity increases. So this is what we actually have to see in a case of polycystic ovarian disease. So you want to know the Rotterdam criteria for polycystic ovarian disease. 2 out of 3 should be positive here. So what are the 3 parameters? One is the clinical feature, second is the biochemical feature, and third is the radiological feature. So let's discuss each one of them. Clinically, they will give you irregular menstrual cycle. So there can be oligomenorrhea or anovulation, oligomenorrhea or amenorrhea, and it is centered around anovulation. What else you will get here is hirsutism. You don't get obvious virilization, you get hirsutism more commonly. Remember, so a few words about hirsutism itself. So for hirsutism, there is a score called Ferryman-Galloway score. So you should know about it. So there is Ferryman-Galloway score. Any score more than equal to 8 is a higher chance of hirsutism. Okay. So this is what is clinically significant hirsutism. It basically looks at the amount of coarse hair that are there, around the body. So this is Ferryman-Galloway score. Now, biochemical wise, what we have to check is that the testosterone levels are going to be raised. But what is very important is, what about androstenedione and DHEAS? So what you want to remember, that DHEA and DHEAS, they should be normal because these are adrenal origin. So whenever in the case of virilization, you find that DHEA, DHS are raised, that says that it's an adrenal source reason. It's not a PCOD source, right? So that's very important. When we look at testosterone also, again, the values give you something. So testosterone raised but less than 150 nanogram per DL is what you expect in PCOD. If the testosterone is more than 150 nanogram per DL, then look for a virilizing ovarian tumor. Okay. So anytime you have history of virilization, hirsutism, look at testosterone levels. That tells you whether it's PCOD or it's a virilizing ovarian tumor. We're going to talk about it. This could be your thecomas tumors, right? So these are your thecomas or arenoblastomas that I teach you, but the levels tell you, and DHEA, DHS tell you about an adrenal source, right? So this is the biochemical parameter. And actually, what is the hallmark in PCOD is LH by FSH increases because LH values increase here. And that again gives you a perspective. Why is the stroma increased? The stroma, the theca cells is what are supposed to make the LH, is supposed to act on the theca cells, and that's why they are increased, right? So that is what gives you a perspective that this LH is what is going to stimulate the theca cells, and that's why the stromal volume increases. You see how everything is so interlinked? We just had to fit that puzzle with the concept, okay? So this is about biochemical. Don't argue that it's 10 follicles, 12 follicles, 20 follicles. There are 1,000 guidelines, right? So everybody follows their own guidelines. We don't even count it in practice. What we have to see is all of the follicles should be arranged in periphery. So the follicles are arranged in the periphery. You know this. This is called as pearl necklace appearance. And what is very important is there should be no dominant follicle. Very important, because the whole point of PCOD is there is no ovulation happening. So there should be no dominant follicle, and the stromal volume increases. Overall ovarian volume increases. All right. So if you want to remember a number, remember 10. So the ovary is more than 10 cc. The follicles can be more than 10 to 12, and each of them have to be less than 10 millimeters. Things come here. So Any 2 out of 3 positive, this is positive diagnosis of PCOD. Lots of questions come from the management of PCOD. So for management of PCOD, you want to remember first and foremost, always, this is where your question will stop. This is lifestyle modification. First, ask the female to lose weight. That improves ovulation, right? So the main problem here is insulin resistance because of the higher visceral fat. We talked about it. They are the ones producing this aromatase, converting the androgens. High levels of estrogen, high levels of androgen getting converted to estrone. So you cut down that so that there can be more estradiol which gets produced. Okay. So lifestyle modification is what is very, very important. Then you have to see what is the problem. If infertility is the main concern, then what are you going to give? Then letrozole is preferred over clomiphene citrate. The concept here is that anytime FSH is normal, which it is in this case, the drugs are letrozole and clomiphene which are preferred. If FSH is abnormal, then we give HCG or HMG that we do in IVF, right? So that's the concept here. Here FSH is normal, so these are the drugs which are preferred. But if a woman does not want fertility, she has come to you with irregular menstrual cycles, then what do you want to do? Then you're going to start her on OCPs. If her concern is hirsutism, OCPs will take care of it. But if it is not responding to OCPs, then only will you add spironolactone. Okay, so this is if the hirsutism or virilization effects are very, very high and they are not responding to OCPs. So this is your whole question on PCOD. Many questions have come from this. Okay, almost every year one question. Apart from that, when you see enlarged ovaries, but now the follicles are also large. Now what do you consider? Now you have two differentials here. One, if they give me history of in vitro fertilization and a female comes to with acute pain, abdominal distension, what I want to think of? I'm going to think of OHSS, ovarian hyperstimulation syndrome. The beta HCG for stimulating ovaries. That's why the ovaries are hyper. If they give you that the female has molar pregnancy, means this molar pregnancy now is producing a lot of beta HCG. What is the diagnosis? These are called as theca lutein cysts. Okay, again, you don't need to treat them. You treat the molar pregnancy. These will resolve on their own, right? So whenever you see large follicles, these two are the possibilities. Moving on to abnormal uterine bleeding, very, very important. So abnormal uterine bleeding. Here, one number is important. That what is the normal length of the menstrual cycle? So you want to remember normal menstrual cycle length is anything that ranges between 24 to 38 days. This was asked this time. So 24 to 38 days is normal. Any bleeding which goes on for more than 8 days or more than 80 ml. So these are the numbers: 24 to 38 days, more than 8 days, or more than 80 ml is a heavy menstrual bleeding. The most common cause of this in young females, right? So the most common cause of abnormal uterine bleeding is anovulation, particularly in perimenopausal women and in young girls, right? So this is what you need to know. But what are the causes is given by the Palm-Cohen classification. Very high chances of this getting asked. Okay. So P for endometrial polyp. We have studied in polyp. It shows you this feeding vessel sign. So this is what you are seeing on Doppler, that there is a vessel. This is the feeding vessel sign. All right. Apart from this, another extra point for polyp is there is something called as saline infusion sonography. Okay, SIS is what we call it. So this is where you are going to put saline in the endometrial cavity, and then you can visualize the polyp better. For example, this is the endometrium, right? When you put saline, saline is black on ultrasound, so you'll see this white polyp shining out, and there is fluid surrounding it. What this is useful is to distinguish a polyp from a submucosal fibroid. Sometimes there can be a submucosal fibroid also in the endometrium. So then that submucosal fibroid, when I put saline, is going to be attached to the wall, whereas polyp is going to be floating. So this is polyp versus leiomyoma, and that can be done very nicely on a saline infusion sonography. Okay, this is an extra point if this comes party. So lots of party questions are there in this video, all right? So beware. So this is what is polyp. Then you have adenomyosis, we'll talk about it. Leiomyoma, we'll talk about it. Endometrial cancers and hyperplasia. Coagulopathy, ovulatory dysfunction, we said was the most common cause. Any endometrial cause, iatrogenic or non-classified. So you need to know this full form. Now let's talk about other pathologies. So what do we see here? Look at this ultrasound and MRI. This is where they will talk about history of a female who has dyspareunia. There will be dysmenorrhea. Look at the uterus. The uterus will be enlarged, but there will be symmetrical enlargement. Very, very important. Symmetrical enlargement. The uterus will be tender on palpation and usually less than 12 weeks POG, meaning the size is less than 12 weeks, right? So symmetrical, tender, all of these are pointers favoring adenomyosis. Very, very important. All right. So what you see on ultrasound, basically the pathology in adenomyosis is the endometrial glands and stroma are present at the junctional zone. So what you're going to see are these areas of shadowing. This is what is given the name of Venetian blind appearance. Okay, you can see these shadowing at the junctional zone. So MRI is the investigation. This is where you can see this is a sagittal T2-weighted MRI. You can see bladder, spine here, this is the uterus. You get the bulky uterus. This white in the center is the endometrium, and this is the myometrium. And you can see on this side how there are these white areas which represent the endometrial glands and stroma. So this is what is given the name of salt and pepper sign. Alright, so these are all the things about adenomyosis. On the other hand, a fibroid, they're going to give you history of heavy menstrual bleed in a fibroid, and what they will describe is asymmetrical enlargement, no tenderness. Asymmetrical can occur anywhere. So this is what a fibroid looks like on MRI, very much enlarged heterogeneous appearance because of the various degenerations that it tends to undergo. So this is the WHO FIGO classification, hasn't been asked so far. So party question. So what is the classification? You want to remember 0, 1 and 2 are submucosal. It's projected in the uterine cavity. So 0 is ekdam intracavitary, pedunculated. It should be less than 50% intramural, more than equal to 50% intramural. So these are 3 submucosal lesions. Submucosal fibroids are the most problematic one. They can present with heavy menstrual bleed or infertility, and these are actually amenable to myomectomy. So this is where you can do myomectomy if they cause heavy menstrual bleed or infertility. On the other hand, look at 3, 4 and 5. These are essentially 3 and 4 particularly are your intramural ones. So 3 is 100% intramural, 4 is also intramural, but 3 also contacts the endometrium. 5, 6 and 7 are your subserosal. So look at 5, it is more than 50% intramural, 6 you can see is less than 50% intramural, and 7 is in the pedunculated. So that's how you have to remember. 0, 1 and 2 go as a category submucosal, more and more inside. 3 and 4 go as a category intramural, one is contacting endometrium, one is not. 5, 6 and 7 subserosal from outside, more outside, and 8 means anything else, cervical, parasitic contact with the uterus. What you need to know about fibroids. With this, we come to an end of gynae part, barring the cancers, of course, which we'll be discussing in the very end. But now we start with the major chunk. So this is not 50-50 of gynae, it's 20-80. 20% of gynae, 80% we're about to start, that is obstetrics. So extremely important. So let's start. For basic obs, what you need to remember, we have the Nagel's formula. So anytime you want to calculate the estimated delivery date, you're going to ask the female's LMP, and you have to add 9 months and 7 days to it, and that gives you the estimated delivery date. 2 times asked question, what is the best if the periods have been irregular or a woman was on OC pills? In that case, what you will use to calculate the ED is then the crown rump length. So this is the ultrasound that you do in the first trimester, and that is what gives you the crown rump length, and that is the best parameter for gestational age overall. Okay. Then you need to know about the GTPAL score, very important. So whenever we say gravida, it includes the total number of conceptions. current pregnancy? Yes, obviously, right? So if a female has had 3 pregnancies, she becomes G3, including the current pregnancy. And then T, matlab number of past pregnancies which have reached a stage of viability, which is taken as more than 28 weeks. For example, a woman who has had 2 previous deliveries, both at term, and she's pregnant now, the abbreviated score becomes G3P, like that. The detailed score is GTPAL score, where now you add 4 things. So first is term. Term matlab any POG more than 37 weeks. Preterm matlab anything between 20 to 37. This is where now the viability is taken as 20 weeks. Abortion matlab anything beyond or below 20 weeks. And L matlab live issues. All right. So, for example, a woman has had 1 abortion, 1 preterm, 1 term. Then what happens? What is the score? So, 1 term, 1 preterm, 1 abortion, and let's say 2 were the live ones. So, right now she has 2 kids. So, this is the detailed score. Most of the times they're going to ask you with a twin delivery, right? So, they'll tell you that a woman comes to you is currently pregnant and she has delivered twins in the past. Now, what is her score? So, what will be the Gravida score? She's had only 2 pregnancies, even though she got 2 babies. Pregnancies were 2 only, right? So, including 1, she has been pregnant. The detailed score now will be 1 plus 0 plus 0 plus 2. So now only live issue will the twins come into picture. Alright, so this is the most trickiest part that you need to remember. So now let's talk about the uterine size. Okay, so this is very, very important. What does it correspond in terms of weeks of period of gestation? So when it reaches the pubic symphysis, the uterus grows and reaches pubic symphysis, this corresponds to 12 weeks POG. This is what we said in adenomyosis, right? That up till this point it is usually seen. Umbilicus is 20 to 22 weeks period of gestation, and Ziffy sternum is 36 weeks. This is important because what beyond 36 weeks, it can't go higher. Then it descends down. So that is what is called as lightening. So around the 36 weeks, this is when a woman experiences lightening. Okay, so what is this lightening? She feels lighter. She breathes better because now that baby and the uterus was constantly engorging on the diaphragm, now suddenly is going down so she can breathe. Okay, so this is when the descent happens, is when the engagement starts to happen. Okay, so this is called as lightening, happens at 36 weeks. Don't confuse lightening. A lot of students do this with quickening. What is quickening? It's when the movements are felt first. This happens usually around 18 weeks. In primary, that is usually later by 1 or 2 weeks, but roughly 18 weeks. Okay, so that's what you want to remember. While you're remembering this, also remember internal ballotment. This is a repeat question. Internal ballotment happens at around 20 weeks. Okay, very important. What are the tests that you're going to do at the initial ANC visit? So hemoglobin blood group, very important. If a female is Rh negative, in that case, you also have to do husband's blood group. If that comes out to be positive, then what to do? We will see in Rh topic. Okay, so VDRL, HIV, rubella, IgG, very, very important. These are to be done. We've already talked about what happens if rubella, IgG is negative. Remember, rubella, IgG positive means normal, she is immune. But if it is negative and IgM is positive, means she is infected. Okay, but if IgG is negative, means she's not infected, but she doesn't even have immunity. Then what you have to do is, right now, don't do anything. You can't vaccinate her during pregnancy. You don't have to give her immunoglobulin. You will wait and postpartum you give her the vaccine. Okay, so that is important. H-base antigen is optional. It's not mandatory. That's why I've kept a plus minus here, and urine routine microscopy is done. What is very, very important here is that we're also going to do, according to Indian NIPSI guidelines, we're also going to do an OGTT at initial visit. So OGTT is done first visit, and then it is done. If it's negative or normal, then it is done at around 24 to 28 weeks POG. All right, so that's your oral glucose tolerance test. The vaccines that are to be given, so you can give TD or Tdap. If you're giving TD, that can be given at initial visit as well. But Tdap is to be given around 27 to 30 weeks, 27 to 36 weeks, and there are 2 doses of both TD and Tdap. 4 weeks apart. But if her last pregnancy was within 3 years, right, so 3 years, then only 1 booster of TD she has to take. Okay, so that is about TD. She can also take influenza vaccine. Live vaccines are contraindicated in pregnancy except yellow fever. So this is what we have discussed, that yellow fever can be taken in pregnancy. Let's talk about these Leopold maneuvers now. So you have gotten image-based questions from this. So what are the Leopold maneuvers? So the first one is where you are keeping your hand at the fundus. So this is what is called as the fundal grip. So here you are trying to feel what is the part at the fundus. Is it the head? Head will be a firm structure, whereas what is fundal grip. Then your hands are on the side lateral. So this is lateral grip or umbilical grip. This is again to see the lie of the baby. What side is the back, which will be the firm structure. What is the empty part, where you have the feet of the baby. Okay. Then this is where you have one hand. You know how animals have paws? One paw is one hand. So when you have one hand at the pelvis, remember this is pollic grip. Okay. This pollic grip is to see the presenting part. What is the presenting part? Is it cephalic? Is it breech? So this is pollic. Whereas now we're coming from the other side. Now we're facing the mother's feet. So people confuse pollic pelvic. Actually, the confusion is lateral versus pelvic grip. So here you're facing the mother. Here you're facing the mother's feet. That's what you want to remember. So this is pelvic grip. And here you are seeing the attitude, fetal attitude. Not that fetus is good, positive attitude, or negative attitude. What this means is the flexion. Okay, whether the baby's head is flexed, deflexed, extended, and what that will do to the presenting diameter is what we will look at in a few hours. All right. So this is about the Leopold maneuvers. A few signs. All of these signs happen around 6 to 8 weeks POG. So these are early signs. One mnemonic for each. Jackie Chan. You know how we have Jackie Chan? Jackie Chan. Jackie Chan turned blue. He's doing so much gymnastics. He became cyno. So that's what you remember. Jackie Chan. Blue. Bluish hue. Oceander. See side. You can take out side here. Side matlab lateral fornices. So increase pulsation through side lateral fornices. You know how we say goody two shoes? Now remember goody two soft. So goodle is soft cervix. Pissacac sounds like pitchkawa. Pitchkawa means asymmetric, so asymmetric. Hagar. So let's say you meet a friend, you say, hey. So now here you have 2 hands. You're doing a bimanual exam. One hand is in the abdomen, one is in the vagina. Both of them are like, hey, what's up? So this is bimanual examination. Hagar, the abdominal and vaginal finger opposed below the body. Palmar. Do you remember in ortho we had done this test, Roos test? What were we doing? Can I say I'm doing a rhythmic contraction of my palms? Yes. So that is Palmar, rhythmic uterine contractions. All right. So this is how one mnemonic you will remember all of these early pregnancy signs. We've already talked about this in radiology, but just to repeat and complete it. So this is where we talk about early pregnancy ultrasound. So the first change that you see on ultrasound, yes, is the gestational sac. On a TVS, we can see it as early as 4.5 weeks, whereas we know that in TS, you've got to add 1 week to this. In a gestational sac, it usually implants eccentric to the midline, and that is what is called as the intradecidual sign. And you're going to see 2 decidua surrounding the G-sac, that is called as the double decidua. Don't confuse it with double bleb sign, okay? So that's double decidual sign. The 2 decidua are capsularis and parietalis. Remember CP, capsularis and parietalis, right? So this is what we need to know about gestational sac. It's the very first change of a pregnancy on an ultrasound. You call her after 1 week. What are you going to see? You are going to see the yolk sac. So this G-sac keeps growing roughly at 1 millimeter per day size, and you see within the G-sac there is a yolk sac. Call her after 1 more week. So now we are at 6.5 weeks. This is where now you can see this is the G-sac, this is the yolk. You can see the embryo appearing. So this is what a fetal pole, all right? So this appears at around 6.5 weeks on TDS, and as soon as the fetus comes, the first system to develop is the heart. So the fetal heart rate or the fetal heartbeat is first heard at 6.5 weeks on an ultrasound, and this here is the surest sign of viability. Very, very important, right? So beyond 6.5 weeks, we can say whether the pregnancy is viable or not. Before that, we can't, all right? So this is very important. 1 week later, now you have these two blebs coming in. So can you appreciate the GSAC? Now there are two blebs, okay? So look here. You can see the embryo. What surrounds the embryo is the amniotic sac, and around it is the yolk sac. So this is what has been described as the double bleb sign. Don't make a mistake. It's not G-sac. What are the two blebs? It is the yolk sac and the amniotic sac. All right. So this is what you need to remember for the two blebs. Right. So 1 month later, so G-sac 4.5, yolk sac 5.5, fetal growth 6.5, and 7.5 is when you have the double bleb. Another important point. Once you see the fetus, now this is the fetus who's going to develop the cranium, the buttocks, the limbus develop. So this is where we estimate the crown rump length from top to bottom. So this is what you need to remember is the crown rump length. This is the most accurate parameter for gestational age, and this is measured in the first trimester. Remember that. So now very, very important. We're talking about physiological changes in pregnancy. You get a lot of questions and it can't get easier than this. But you have to remember all of these things increase, all of these things decrease, and all of these things remain constant. So this is very, very important. Let's discuss each one of them for the hematological parameters. So the most important thing that happens in pregnancy is the blood and the plasma volume particularly increases. Even the RBC volume increases, but the plasma volume increase is much, much greater, and that is why the hemoglobin and hematocrit decreases, right? Because of dilution. So this is physiological dilutional anemia that happens. What you need to remember, plasma volume increases in response to estrogen as well as aldosterone. This is a repeat question. The retic count, WBC count, clotting factors, fibrinogen, ESR, all of these things increase. So if you look at the blood work of a pregnant female, it looks like she has infection. But WBC is increased, the ESR is increased, but it's not. The platelet decreases, all right? So thrombocytopenia also inflammatory, that goes down. So it is just physiological increase. So that's what you have to be aware of. All clotting factors increase except factor 11 and 30. So you remember having CH table, we did all ones were increasing, now do it ulta. 1 and 13 go down, all right? Albumin goes down. So very important, total protein increases, but albumin is going down, and that explains the fact why edema develops in pregnancy, right? If you've seen like feet of pregnant women in third trimester, they're swollen because edema, right? Albumin decreases. Protein CNS decrease, and very important, the steroid hormone binding globulin and thyroid binding globulin increase. The significance of this PBG increase is what? Now more hormone is going to be bound at means that free T3, T4 will fall, and as soon as it falls, it's going to stimulate the thyroid to produce more. So overall picture in pregnancy is going to be that total T3, T4 is going to increase. But what about free T3, T4? That remains constant. Make sure that you are euthyroid. So TBG increase or increases. What about TSH? Very controversial. So you want to remember TSH remains normal except first trimester where it may go down. So if they don't specify, just say TSH is normal. But in first trimester it decreases slightly because of the common alpha subunit. Because HCG is doing the job, TSH like why should I rise there? So that's why it drops. Okay, so this is very, very important. But if a woman is already hypothyroid, taking drugs, taking levothyroxine, what should you do to her dose? Have to increase it, right? Because TBG increases, more hormone is going to be bound. So if she is hypothyroid, you got to increase the dose. But a normal pregnant female remains euthyroid, just that her total T3, T4 will be increased because bound is increased, right? What about cardiac output, heart rate, stroke volume? All of these things increase. Now the cardiac output increase, extremely important. We'll discuss this as well. This increase is maximum immediately postpartum, followed by second stage of labor when she's bearing down, followed by 34 weeks. So 34 weeks it is maximum, and then it goes a little down, right? Very important, the peripheral vascular resistance decreases, and that explains the drop in BP of a pregnant woman. And because diastolic is majorly dependent on the peripheral vascular resistance, the fall in diastolic blood pressure is far more than systolic blood pressure, okay? Whereas ejection fraction is constant, all right? So that's what we need to remember. Respi extremely important. Remember the mnemonic. ICTV movie increases. We watch more movie, in pregnant, you have more time, you're matthew. So ICTV movie increases, whereas FRC and residual volume have a drop. Everything else is constant. So just remember these 5 things. ICTV movie increase, FRC residual volume mild decrease, and others are constant. Because plasma volume increases, renal blood flow increases, and GFR increases. More GFR matlab urea creat drop. Fine. So that's what you need to remember. Apart from that, pH decline because the lactobacilli increase. All right. In addition, in pregnancy, we have already seen that there is pigmentation. The hormone pigmentation is estrogen, right? So estrogen is responsible for 2 things. It is what is responsible for the plasma volume increase, and it is what is responsible for chroasma, linea nigra, the black line down her abdomen, right? So all of these things are also because of estrogen. Okay. This is a pregnancy tumor. This is what is called as a pyogenic granuloma, also called as gravidarum. This is a tumor which regresses after pregnancy. This is a pregnancy-related lesion, right? So that's what you need to remember. Not always in the gums, but it's this reddish vascular lesion that can be seen anywhere, right? So just remember, if you give pregnancy, this is gravidarum tumor, pyogenic granuloma. Next, very important, we talk about aneuploidy screening. So in aneuploidy screening, what you want to remember first are ultrasound methods. So you have NT. We do this NT-ND scan, nuchal translucency nasal bone scan. This is done in the first trimester at 11 to 13 weeks period of gestation. Technically, this can be done till 14, 11 to 13 plus 6, matlab, just before 14 weeks, right? So this is when you can do this NT-ND scan. This is where, look at this, this is the plane that you have to take, and we measure this nuchal translucency, essentially measuring this fluid collection behind the nape of the neck. So the maximum diameter needs to be measured. So this is how we place the calipers, and we measure NT less than 3 mm as a general rule is normal. Basically, it depends on the POG. There are exact readings, but at your level, less than 3 mm, normal. And we also check for nasal bone. Do you see this equal sign here? 2 white lines. That indicates that nasal bone is present. So raised nuchal translucency and absent nasal bones are related with aneuploidy. So increased nuchal translucency linked with aneuploidy. Obviously, that's what you are checking. But if aneuploidy is not there, it is also associated with CVS anomalies, right? So that is what is very important. Nuchal fold thickness, on the other hand, is measured in the second trimester, and this is where more than 6 mm is abnormal. So you want to remember, first trimester 3 mm, second trimester 3 to the 6, more than 6 mm abnormal, again linked with aneuploidies. Now coming to biochemical tests, so dual markers are done in the first trimester, whereas triple and quadruple are done in the second trimester. So dual marker is what is including HP. So one of the first laptops that you buy is HP laptop, right? So remember HP, and Papa only gets you that laptop, so Papa. So you want to remember HP dual marker. Triple marker, Do you remember BJ story? Hey, I am. So this is where the story comes to an end. So this is where there is somebody who is approaching you and saying, hey, what's up? So what is hey? It is hey with the wrong spelling. So this is HCG, alpha fetoprotein, and what is E? This is estriol, triple screen, triol, E3. All right. So we have seen E1, we have seen E2, now we meet E3. So there's this person who's coming to you and saying, hey, with the wrong spelling. You're like, who are you? So he says, I am. So this is where quadruple screen, you want to remember, it is I am, not IB, because in B we will study granulosa cell tumor. So you're just sitting somewhere, sipping a coffee, and somebody comes to you rather odd looking and says, hey, like, hey, who are you? I don't know spellings. So he says, I am, makes quadruple screen. And you know what he says? He says, I am BJ. Do you remember this from PSN? I am BJ. Right arm, IPV, MMR, DCG, JE. First two intradermal, next two subcutaneous. So he said, I am BJ, and he offers his hand. So he's trying to shake your hand, shaking hand cast. What was this? This was Cooley. So he's shaking your hand, saying, hey, I am BJ. So you shake his hand. But then you find out that he is actually by occupation a proper Gunda. What is proper Gunda? So this is the sequence: pronation, palmar flexion, ulnar deviation. So now you find out his occupation, and now is he going to release your hand? He isn't, because he cannot terminate grip. Why? Because CTG, he has myotonic dystrophy. He does look like a Gunda. We have seen it in general paths. So he has hatchet facies. He's a Gunda. He's autosomal dominant. He also has Christmas tree cataract. Right? So this is all that we know about our BJ, and the fact that he's 19 years old because he's chromosome 19. So this is all your story across different subjects. So we are doing the last subject. So this is what was the beginning, PSM, ortho, path. All right, so this finishes our BJ story. So going back, so this is the utility of hey, I am. So HCG, alpha fetoprotein, estriol, and inhibin A. All right, this inhibin A test is what is also referred to as BARD or Kettering test. All right, so that is what you need to remember. Now, what happens in Downs? That's particularly something that you need to know about. So in Downs, just remember H is high and inhibin I increases. Everything else goes down. So what we're gonna see, HCG high and inhibin A increases and everything else is decreased, right? So that's how you will know what happens in Downs. All right. NIPT, what you need to remember, this is a non-invasive prenatal testing. So this is where we are checking cell-free fetal DNA from the mother's blood. All right. So we can actually have some fetal DNA from the mother's blood. So non-invasively we can actually test for aneuploidies. Now, you know the utility. You do all of these, biochemical, radiological, together it gives you 95% sensitivity. This one test alone gives me 99% sensitivity. So should I do it in everybody? You can't do it in everybody, because this also gives you the karyotype. So you'll know the fetal sex, and that's something which we cannot have for general public. So this is what is for high-risk patients only. So this is where either you have a family history of aneuploidy or a personal history where you had a child who's had aneuploidy, only then is NIPT recommended. So this is very, very important, and despite its sensitivity, this is still a screening test. So this brings us to the most important thing, that if any of these are abnormal, dual marker, triple marker, quadruple marker, NT, NFT, NIPT, all of these, what is the next step? Next step is karyotyping. For karyotyping, we need fetal cells, which can be taken by three methods, most commonly amniocentesis in the second trimester, chorionic with a sampling in the first trimester, around 10 to 13 weeks. Chorionic with a sampling has higher chances of fetal limb defects. That's why we don't recommend it. But amnio is most commonly done, where you take amniocytes or fetal dermal fibroblasts. Photosynthesis is almost never done for aneuploidy, okay? It is only used for intrauterine transfusion that we are going to learn in RHI immunization, okay? So this is something which is not done. So this is something that you have to remember about aneuploidy screening. So now what we are going to discuss are three topics, all to do with first trimester bleeding, okay? Extremely, extremely important. So whenever you have somebody who comes to you with first trimester bleeding, there are four possibilities. Starting with the most benign one, usually at the time of implantation, you may have a bleed. So that is implantation bleed, which is, going to stop on its own. So this is something you can ignore. But three conditions where you will have bleeding, pain, what are those? So first one, ectopic pregnancy. Second, abortion. And third, molar pregnancy. Very, very important. In ectopic pregnancy, you will get bleeding, you will get pain, and they'll describe something very, very important. If the pregnancy has ruptured, you're going to have a patient who's in shock, and there is something they'll describe that is cervical. They'll describe something very, very important. If the pregnancy has ruptured, you're going to have a patient who's in shock, and there is something they'll describe that is cervical motion tenderness. So this is your buzzword for ectopic pregnancy. In fact, cervical motion tenderness can be two things. One is ectopic pregnancy, one is PID. So both things very different spectrum clinically, so you can distinguish. So remember this pattern. Abortion, we will talk about it. We have to look at the os and the side. Molar pregnancy, you will have very high levels of beta HCG. Whenever that happens, there are three very unique things that can accompany a molar pregnancy. One, they will give you history of hyperemesis gravidarum, right? So more morning sickness in the first trimester. Second, you can have hypertension. Normally PIHV says more than 20 weeks. That's what we're going to learn. But here you may have hypertension within 20 weeks as well. So that's unique. And you may also have hyperthyroidism because of these very high levels of beta HCG, because we know that the alpha subunit is common, right? So this is what is very, very important. These are your buzzwords to lead you up to these diagnoses, and then we will see the details, all right? So let's start with ectopic pregnancy first. So ectopic pregnancy in its unruptured state is going to look like this. You're going to see an adnexal cyst And you're going to see that there is this ring of fire appearance or a bagel appearance, basically saying that there is peripheral increased vascularity. All right. So whenever you see this, consider an ectopic pregnancy, particularly if you can see a fetal heart rate within and a uterus which is empty. So ectopic pregnancy, you will have an empty uterus. If you have uterine pregnancy plus ectopic pregnancy, that's what we call as heterotopic, okay, which is very, very rare. So this is ectopic pregnancy. Another differential for a very similar appearance is a corpus luteal cyst. This is very common. So this is where you will have a uterine pregnancy. The uterine pregnancy and just a corpus luteum cyst, this usually regresses in the second trimester, right? So that is what you have to just remember as a side note. I'm telling you that one of the differentials is this, but don't get confused. In your exam, remember ectopic unless they say that everything else is normal uterine pregnancy, then just have this in the back of your mind. Now talking about the management, that is where most of the questions will come. So if you have a ruptured ectopic, now what do you have to do? There is no option. A female will be in shock, diffuse pain, abdomen, low blood pressure. You have to do exploratory laparotomy, and you don't even have time to do laparoscopy. So you do an exploratory laparotomy and you remove, right? So you do a salpingectomy. But if it is unruptured, now you have two options, medical versus surgical. In surgical, now you can do a laparoscopic surgery where you can either do salpingectomy or salpingostomy. Salpingostomy is what is favored if the family is not complete or the other tube is also damaged or there is history of PID, then you don't want to remove the tube, right? So obviously family is not complete is not the thing here because either ways the woman does want a pregnancy. So salpingostomy will be done if the other tube is also damaged, then you can't remove the other tube, right? So that is where you have either PID or other indications. Anyways, what you have to remember is what are the indications of medical management. So one, the woman has to be stable, she has to be motivated because now she has to come for follow-up. She has to come to us for follow-up for a long time, right? So we are going to see that she has to come for many days to monitor beta HCG. So she has to come for that. Extremely important, HCG value should be less than 5,000, fetal cardiac activity must be absent, and the sac should be less than 3.5 centimeters in size, all right? And no contraindication to methotrexate. What are contraindications to methotrexate? You have hepatotoxicity and pulmonary fibrosis. So if these are not there, you can go ahead and do medical management where you're going to give a single dose of methotrexate intramuscular, which is usually 50 mg per meter square body surface area. So this is a single dose intramuscular, no folinic acid, no serial injection is what you have to remember. Day 4 and 7, you are now going to monitor her beta HCG. If less than 15% decline, you will repeat one more injection. Again, not serial, one more injection, and you keep monitoring beta HCG until it becomes 0. Right? So this is what you need to know about ectopic pregnancy. A few questions about ectopic. The most common site where the implantation happens in the fallopian tube is ampulla. Apart from this, the one which lasts the longest, right? So the one which can go on the longest is cornual ectopic or basically interstitial ectopic. So here I'm talking about fallopian tube, all right? So this is what you need to know, and one of the major risk factors of ectopic. Anytime they ask you any risk factor, the biggest risk factor is always past history of ectopic. So that's fine, that is the biggest risk factor. But what they can ask you is, so past history of ectopic. Apart from this, what they can ask you is which contraceptives can lead to ectopic pregnancy. So there you have to remember that tubal ligation is the biggest risk factor. If they don't give you tubal ligation, then mark IUD, all right? So tubal ligation, otherwise IUD. So this is what is very, very important. Now talking about few criteria. So other ectopics, cervical pregnancy, you have Palman and Rubin's criteria. For ovarian, you have Spielberg. And for abdominal, you have study form. And remember, abdominal pregnancy, stud pregnancy. Why? Because this can go until term also. Abdominal is not for space, right? It can go until term also. And what is very important is the placenta here can sometimes invade into bowel, can invade into peritoneum. So it may not be easily removed. So here, if the placenta is not removed, you can just retain it. You can keep it. And then maybe give some other drugs like methotrexate. But if you try to remove it, may lead to other complications. So that is unique about abdominal pregnancy. Something unique about cervical pregnancy is you may have to distinguish a cervical ectopic versus an abortion, right? What if an abortus is there in the cervix at the time of ultrasound? So for that, what we do is something called as the sliding sign. You have an ultrasound probe, you try and press on it. So if it is an ectopic, it's not going to move, it's implanted. But if it is an abortus, it will slide, right? So that's how you can distinguish this. Now talking about PUL, extremely important, pregnancy of unknown location. This means that the UPT of a female is positive, but the uterus is empty. Means female is pregnant, but we don't know there is the baby. So now there are three possibilities. What are the three possibilities? One, that you are way too early. It's an early pregnancy, and that's why you're not seeing it. We said, right, it can be seen at 4.5 weeks and beyond. So we are not seeing it. Second is, it is ectopic. Third is, it is already complete abortion. How do we distinguish? What is the next step? So the next step is beta HCG, and the best answer is serial beta HCG. Serial beta HCG 48 hours apart, because 48 hours is the doubling time. If we see that the beta HCG doubles, it means it's a normal early pregnancy. If we see it increases, but it doesn't double, it plateaus. That means it's ectopic. Beta HCG is getting produced, but not at the rate at which uterus should produce. And if it declines, it is abortion. So this is how serial beta HCG helps us. One more concept you should know here is that of discriminatory zone. What is discriminatory zone? It is the beta HCG at which an intrauterine pregnancy, if present, should be seen. So on a TS, that is more than 6,000. Beta HCG is more than 6,000, you should be seeing a sac. Same thing, for TVS should be lower, that is more than 2,000. So this is what you need to remember as discriminatory zone. So extremely important page here, you get minimum one question from this, right? So it's ectopic, PUL, other criteria. Now talking about molar pregnancy, extremely important. We've already seen the scenario, very high levels of beta HCG. Now look at the ultrasound appearance here. So what you see is within the uterus, you can see so many sacs. One more thing they can give you here is that the fundal height, because there is so much expansion, this fundal height could be greater than the POG. So that's one more pointer. And what you see here are all of these cystic spaces. This is what is called as cluster of grapes appearance or snowstorm appearance. And what this represents is the hydropic degeneration of the villi. So here the chorionic villi have degenerated. If there is complete, it is complete. If there is focal degeneration, that is a partial mole. In a partial mole, you are also going to see fetal parts. All right. So some degenerated fetal parts may be seen. And something unique which I feel may be tested is P57 immunostaining. So if P57 they give, all of these three are going to favor partial mole. All right. So now looking at the genotype here. So complete mole, complete, either diploid or tetraploid, and complete pura father's genome. So pura paternal. That's how you remember complete. So look at this. This is where the ovum is empty. So you have a sperm coming in, either that duplicates or there is there are two sperms, so there is tetra diploid, so it is complete. Whereas partial matlab आधा, there is dispermy with an ovum, so this is triploid, and the extra set is paternal. So this is what is about the molar pregnancy. How do you want to manage? So very important, the management is suction and evacuation. We know we are not going to do curettage because that leads to Asherman syndrome. So suction and evacuation, and then you follow up the female for beta HCG. So that brings us to GTN. Why do we follow up patients after ectopic, after molar? This is to rule out gestational trophoblastic neoplasm. Now, gestational trophoblastic disease includes molar pregnancy and GTNs. So what does the neoplasia group include? So neoplasia in order of prevalence are four things. Most common, invasive mole, then choriocarcinoma, then placental site trophoblastic tumor, and ETT. ETT is epithelioid trophoblastic tumor. Okay, so ETT, epithelioid trophoblastic tumor, this is something that is very, very rare. So this is what is one of the commonly asked questions. Now, when would you think of a GTN? What is the criteria for a gestational trophoblastic neoplasm? One, the bleeding is persistent. So 3 or 4 are clinical criteria, or in fact 5 are clinical criteria. Okay, so persistent bleed, uterus is not involuting completely, female goes in shock, or we see the theca leucines are not going away. We say they go away once you do suction and evacuation. So they are persistent, and metastasis. When we talk about metastasis, the most common site of metastasis are lung. When you know this is what is called as the Cannon-Ball lesions. Can be seen in any vascular metastasis for that matter, common in choriocarcinoma, and what can also be described as this bluish suburethral nodule. Alright, so this is a bluish suburethral nodule that could represent vaginal or superficial metastasis. Alright, so these are suburethral nodules. These are two common sites of metastasis. Next, you have biochemical criteria. So look at this, very important. Plateau. The beta HCG has plateaued. For that, you need 4 readings over 3 weeks. So 1, 7, 14, 21, plateau. If it is rising, I need 3 readings over 2 weeks. So 1, 7, 14. And if it remains detectable, any value more than 6 months, that is abnormal. And for histopath diagnosis. So this is what you need to know for the criteria of gestational trophoblastic neoplasm. When we talk about the scoring, now this is something which is very, very difficult to memorize, but you have to. So this is where you have 0, 1, 2, and 4. Just remember a broad guideline that I want a value which is more than 7. Alright, so let's look at this. Don't look at the ones which are giving you a 0 score. Look at the high risk features. So age of a woman, more than 40 years. If the antecedent pregnancy was either abortion or term pregnancy, that's high risk. If the interval since last pregnancy is higher, more than 12 is very, very high. Beta HCG as it becomes higher and higher. Size more than 5 centimeter, metastasis number increases, and look at this. Lung does not even feature here. So lung metastasis is a low risk feature. So spleen, kidney, GI, liver, brain. Previous failed chemo with a single drug or 2 or more drugs. So actually just look out for this high risk features in the patient. This has been asked once where they just gave a patient has no other high risk except lung metastasis, which is not even a high risk feature. So this is what is the importance. Now you have to memorize the stage. So stage, the disease is confined to the uterus, extending outside uterus but limited to genital structures. GTN extending to lungs. So you see this lung metastasis is stage 3 and all other metastatic is stage 4. The management, any stage 1 you want to treat with methotrexate alone. Stage 2 and 3, we have to look at the WHO prognostic score. If it is less than equal to 6, you are going to give methotrexate. If it is more than equal to 7, now you have to give multi-drug Imaco regimen. If it is stage 4, any score, you have to give Imaco regimen. So 1 and 4 is clear. For 2 and 3, we look at the score. What is Imaco regimen? So what are the drugs? Here, so E for etoposide, N for methotrexate, A for actinomycin B, and O for oncovin, matlab vincristine. So these are the 4 drugs included in Imaco regimen. So this is a little tricky to remember, but you have to. So this is about gestational trophoblastic neoplasm. So now let's start discussing abortions. Very, very important topic. First of all, the definition of abortion is any delivery before 20 weeks or if the weight is less than 500 grams. So this is what is the definition. This is before the period of viability. So this is what is defined as abortion before viability. So less than 20 weeks or less than 500 grams. Here the approach remains very, very simple. You have to look at the os and then decide. Without that, you can't say. Alright, so that's what you have to remember. First, we look at the internal os. So vowels stick together. So you want to remember os open means the diagnosis has to start with a vowel. Os closed, matlab the diagnosis shouldn't start with a vowel. So this is what makes it